Women+Wellness. And we're very excited about it, and I'm thrilled that you're here. I think everybody in this room wants to be part of something very exciting, very relevant, and something that makes a big difference. It's important you're here, ladies, because you make 80% of all healthcare decisions made in the United States of America. You, for your families, for your parents, when you start to be my age, it's full circle, you start to make decisions for your parents. So we're really thrilled that you're here. First of all, I want to thank our committee, our host committee. Would you stand up? They're the brainstormers behind this whole thing. Would you please stand? Our host committee. Thank you very much. And our co-chairs, our tri-chairs, Meryl and Janine, would you please stand up? Without thanking our staff, because we couldn't do it without you, Courtney, and the entire team, so let's give them a huge round. And our host families. We had many of you in this room host our doctors, and so we were thrilled to do that. Susan, Lynn, you weren't here, but they enjoyed your home very much, so thank you very much. Tracy Marshall, thank you, and of course the Baylesses, the anchor and Charlie, thank you very much. You're fantastic. Okay. Ladies, you're the economic powerhouse of the 21st century. The way you think and the way you act is the way the world does business. You are starting businesses at twice the rate of men and staying in business longer, and women of color 6 times the rate of them. You are responsible for purchasing 85 to 95% of all goods and services that are sold in the United States of America. That's $6 trillion. And it can't all be shoes. Am I right? You're buying cars and you're buying homes. You control 51% of the New York Stock Exchange. You maintain 60% of the wealth in this country. And that is because we live 7 years longer than we do. So, the reason I'm mentioning all of this is because you are a very powerful force in the United States. And that's why, when we did Women in Wellness and talked about what do women want to hear, we want you to be empowered to make the right decisions, leading edge technology, knowing what's the best for your family. So that's why we did this. And I hope you like our brand, because we thought this was in motion. This is like a woman running through the storm, right? So we have a gentleman here, we have a doctor, who I think is fantastic. He wanted to be here to hear what we have to say. Our doctors came from Mass General, and we are so happy that you're here. Thank you very much for hearing me about this morning. I'm turning it over to our fearless leader, and you know who that fabulous woman is. She is our CEO, Dr. Margo Hartman. Margo, please.
In this room really speaks to what Nantucket Cottage Hospital is all about in the most collaborative sense. And I appreciate so much your being here because we're more hospital than you know, and we're more hospital than we were and not as much as we're going to be. And that's largely thanks to our staff. I'd like to ask our staff who are here today to stand up. Hospital to ask people to bring their A game, and we need to fill that with our compassionate and caring staff who are willing to be out here 30 miles at sea in what I say is without a net in order to bring quality care, A game care every day. And I want to acknowledge how grateful I am to be their colleague. Thank you. In addition, our affiliation with Mass General has made us all greater than the sum of our parts, and we have 3 colleagues from Mass General today. Dr. Melissa Wood, Jan Leslie Schifrin, and John Denninger, and thank you so much for taking time to be with us and for your wisdom. I'm just as interested as you are to hear that, so I'm going to turn it right over to Meryl Braylauer, in addition to thanking everybody who has participated in making this happen. This is an extraordinary event. Thank you. Right to my mouth. Oh, yeah. There it is. You heard about hard sex in your life. Okay, so we're really happy to welcome our three MGH physicians who are superstars. MGH physicians are the best of the best. And I think you'll all agree with me after you hear their talks. Each will speak for 25 minutes, and then we're going to follow each with the Q&A for 5 minutes. We'll give you cards if you want to stand up and speak then as well. Sorry. Okay. Anyway, all right. So let me start with welcoming Dr. Wood to Nantucket. The last time we were here was 2001, and we hope she won't wait that long to come back again. Dr. Wood is the co-director of the Oregon Health Program at NGH. In addition to her teaching, research, and clinical work, she's the mother of 4 children, ages 16 to 22. Pretty impressive. She's written 2 books. One is called Smarter Heart, a holistic approach to preventing and healing heart disease for women. And she practices what she preaches. Yesterday she told me that she ran 5 miles and then she bike rode to Wisconsin. Pretty impressive. So we look forward to hearing what she has to say about the differences between men's and women's health. But most importantly, as far as I'm concerned, if the information that you take from Dr. Wood today helps you or helps you save one friend's life, that'll be pretty significant. So, thank you. Next, we will have Dr. Jan Schiffer, who's the director of the MGH Women's Midlife Center. The Midlife Center brings together more than 16 specialties to improve, promote, and advance healthcare for women. Once Dr. Schiffer heard about what we were doing, she was all in. She couldn't have been more gracious or more helpful in helping us choose doctors from MGH's vast array of different practitioners. She runs the Midlife Center, and every year the Midlife Center has a conference, so she knows a lot of the docs who have presented there before. She's a long-time Nantucket devotee. She came as a kid and stayed with the Jared Hoppin, and she comes with her son and husband often, and here recently Memorial Day. So we want her to continue to come and come. Dr. Schiffer is an obstetrician gynecologist. She's following in the footsteps of her dad, who's also a religion. And despite her busy schedule of education, research, and clinical work, she couldn't have been more helpful and more gracious in taking the time to help us. Her specialty is infertility. And honestly, if I was a young woman going through infertility, there was no who I would rather have at my side than Dr. Schiffer. So thanks for all you've done for us. We really appreciate it. Look forward to hearing everything you have to tell us about sex. Okay. Last but not least is Dr. John Denninger. He's an MD, PhD, and Director of Research at the Benson Henry Institute for Mind-Body Medicine. We welcome you back to ACT. It's been a while since you've been here as well, and we hope that we'll bring you back by bringing you down here, and you'll come back and visit us soon. Some of you may have heard a preview of his talk this weekend on Scott Widmeyer's show on Nantucket NPR, where he spoke about resilience. His first exposure to mind-body came when he was an exchange student at the Hangzhou University in China, and that was between his high school and college years. A major portion of his career has been dedicated to the science behind mind-body techniques and helping to explain how it all changes bodies. Nantucket has always been at the forefront of holistic health. And in fact, many of us may have even taken our first Pilates or yoga lessons here. And what better place is there to learn about meditation than right here on Nantucket? So welcome all 3 doctors. We're thrilled to have you here and look forward to hearing what you have to say.
So I just want to say how grateful I am to be here, what a beautiful island you all live on, and I really hope that in the next 25 minutes I can impart some information that will help improve your life. I think there is so much energy here and there's so much potential for improvement in health overall, and I just want to give you some tips about things that I think can improve your overall cardiovascular health. Now, when you do the things that we're going to talk about, not only will you improve your cardiovascular health, but you're also going to decrease your risk of cancer, decrease the chances that you'll ever have osteopenia or osteoporosis, and you'll live a longer, healthier, happier life. I want to start out at the beginning with just a couple bits of information that I hope you can share with friends and family that can save lives. A little bit of heavy stuff at the beginning, and then we'll move on. First of all, I can tell you that I speak yearly around the United States, and one of the things that makes me feel so thankful for having to give up time to leave my family and travel to speak is that people often tell me, if I wouldn't have heard your talk, I wouldn't have gone to the emergency room. And for me, that is the most valuable gift anyone can give me, is to hear that. So we're just going to talk about the fact that symptoms of heart attack can be typical, such as the thing that you usually expect or hear about, which is an elephant on your chest. But women frequently have symptoms of heart attack that are different than the typical symptom. These are some of the things that you have to think about. Chest pain that radiates to the arm pain, jaw pain, breathlessness, or excessive fatigue. Now, some of these can occur for a myriad of really benign reasons, but when they occur out of the blue, associated with nausea, sweatiness, lightheadedness, or other symptoms, you need to call 911 and get checked out. And it's so important that you don't sit home. A study looked at women's opinions about whether or not they would call 911 for themselves, and only 48% of women said that they would call 911 if they had these symptoms, and yet 90% of them said they'd call 911 if their husband had these symptoms. So I think it's extremely important to recognize that we need to take time for ourselves. All of you in the audience are multitasking, taking care of many things, children, parents, responsibilities. But remember, you come first. It's the old adage about the oxygen mask. If you don't put the oxygen on mom, then it doesn't really matter about anything else, because there won't be anyone there to take care of the kids. So these are really the important symptoms of heart attack. Read this, remember this, talk to your friends about it. The next slide, really, we're looking at talking about signs and symptoms of stroke. This is the FAST acronym, which is really helpful in thinking about what could be symptoms of stroke. F is for face drooping or face numbness that's clearly asymmetric, one side of the face affected because of the blood supply to the brain. The next is arm weakness. Arm or leg weakness or numbness, and if that occurs suddenly, 911. Difficulty with speech, whether it's difficulty finding words or with difficulty pronouncing words, both of those are signs of stroke. And T is for time, 911. We visited your beautiful Nantucket Cottage Hospital today, and we found out there's an acute stroke treatment program here with telestroke, telemedicine. And the one thing that can reverse a stroke is the timely administration of clot-busting medication. And it's available here on island. So you need to get to the emergency room so you can receive it. And it's very successful in opening up clots and can really change the course of someone's life. So those are the two heavy slides. Everything else, I promise, is going to be a little bit more light. Now, cardiovascular disease is the #1 killer of women. 1 in 3 women will have heart disease or stroke in their lifetime. And I will tell you that when I was training 30 years ago, it was the rare day that we thought about heart disease when a woman would come to the emergency room with chest pain or shortness of breath. There were a lot of other reasons they could have it, but it wasn't heart disease. That was a man's disease. And then guess what happened? Things started to change. Studies started including women, and we started studying women who would come to the emergency room, and we found out that heart disease is not just a man's disease. Again, 1 in 3 women. The great news is 80% of heart disease is preventable. So again, these were the sort of typical heart attack patients, probably up until about a decade ago. This is my heart attack patient. She's shared her story with MGH in the development newsletter. Young mother of 2 children who experienced a heart attack 8 months after delivering that beautiful baby girl. She's doing incredibly well. She had a condition affecting one of the heart arteries, and she has done just absolutely beautifully with care. But she could have gone to an emergency room, and if the staff there did not recognize that heart disease can affect young women, and she didn't recognize that her symptom of chest pain radiating down her arm that occurred while exercising was something to be worried about, it could have turned out a lot differently. Knowledge is power, and that's really why I am here. I'm going to talk a little bit about the steps that I wrote about in my book, and I'm not here to sell books. Harvard owns this book, and you don't need to buy it because I'm going to tell you everything you need to know. I really, one of the most fabulous opportunities I've had in my life was to run a study in Revere, Massachusetts, funded by the Corrigan-Minahan family. And it was a study that looked at 75 women living in poverty who had extremely high stress, depression, and anxiety levels, and at least 2 risk factors for heart disease. We brought them health and wellness through yoga. We taught them the Benson Henry relaxation response. We connected them with each other, developed walking groups. They had a health coach, regular practice of Tai Chi and mindfulness in addition to these other things, and we managed their blood pressure, their cholesterol, and helped them lose weight. At the end of 2 years, they had a significant reduction in their risk factors for heart disease. At the end of the study, we interviewed these women and looked at the data and put this book together to really highlight the key elements of that, what I think was a really nice study that showed that you can improve health even in women living in the most difficult situations. So if we could make it work in Revere, we can make it work in Nantucket, right? I think. And it was really a 10-step approach. And these were the key pillars of the book and of the work that I do as a cardiologist caring primarily for women. First, physical health. So that's going to include, and we'll go down the list, things like blood pressure, cholesterol, exercise, nutrition, etc. That's very, very important. But I think equally important, as we'll hear more about later, is your emotional health. We now know that depression and stress dramatically increase the risk of developing cardiovascular disease and other illnesses. So we must pay attention. We need to manage our stress better. We need to eat better because eating better helps us feel better, sleep better, and improves, again, our overall health. We also need to look at our relationships because relationships are often a source of stress for many of us. Some of those relationships we need to work on, and others we can foster to improve our own health. We actually did work with Dr. Walter Willett at the School of Public Health at Harvard and found that there's a clustering of healthy heart habits. So people that spend time with someone who exercises regularly are more likely to exercise regularly. Now, it also works in the other direction. If you spend time with people who don't do the right things regularly, then you're more likely to fall down into that path as well. Communication is really important, and I'm going to give you some clues on how you can communicate with your doctor and your healthcare team. Key. Your environment is also important. It's very key that you have a clean home, a sunny home, to really boost your mood and help your sleep. Mindfulness, we have one of the world's experts here who will talk to us about that a bit. And modification, which is the art of changing habits. And that's something that doesn't come easily, but if you practice, you can certainly do. Now, when we talk about physical health, it's really important that you know your numbers. These are numbers like your blood pressure, your body mass index, which is your body weight corrected for your height, and my 2.5-inch heels do not count. Your cholesterol levels are also very important, and we'll discuss a little bit about the numbers that you need to know and what you need to do about those numbers. It's also important to know your family history, and I mean this is really critical data. Like ask if your parents are living, find out what health issues they have, grandparents. The important questions to ask: was there someone that had a heart attack at a young age? Did someone have a stroke at a young age? Were there aneurysms of the brain, the heart, or the blood vessels? Did someone die at an early age without an apparent cause? These are all things that can be linked to genetic cardiac conditions, and these are very important things for you to know and for your family to know, so that when you see your doctor to get that clean bill of health every year, you can tell them, this is my family history. They can help you develop a profile of your own individual risk and give you steps on how you can change behavior and modify these risk factors and have better overall health. Now, the American Heart Association has been wonderful in developing a number of endeavors that have really allowed us to improve heart health for women. One of them is the Go Red campaign. I think most of you are familiar with that, and I really credit the Go Red campaign with educating people like my beautiful young patient so she knew she needed to go to the emergency room. They also have developed a program that's relatively simple, and it is empowering the non-medical community to learn how to manage their risk factors with their medical team. And this program is called Life's Simple 7. And the goal is to reduce cardiovascular disease by 20% by the year 2020. And we're hopefully well on our way. Now, a survey was performed of a large number of Americans, and they asked a number of questions. Number one, do you think you have ideal cardiovascular health? And 39% said yes. They said, well, I walk once in a while. I eat a piece of celery once in a while. I actually don't smoke. I drink those couple glasses of red wine or more every day. I know that's good for me, right? I eat chocolate. I mean, come on, I have ideal cardiovascular health. 54% of these people also admitted that their doctor told them they needed to modify a risk factor. And barely any of them, not many of them at all, knew their cholesterol, their body mass index, blood sugar, or other important numbers. And a big survey looked at Americans' numbers, not what they thought, and found that less than 1% of Americans have ideal cardiovascular health. Now, I know that's a shocking number, but ideal basically means that of the next 7 things I'm going to be talking about, you get an A+ in every one. Most people get an A+ in 5 or 6, but not everybody. Very few, less than 1%, get 7. So there's good news to this story, which is if you do all of these, or you fall into the A+ category in all of these areas, you really, really will be in ideal health. And if you can get there by age 50, it's predicted that you can live up to 40 more years free of heart disease and stroke. Now, don't worry if the clock's ticked and like me, it's gone beyond age 50. You can still modify risk significantly. The first one's smoking. If you don't smoke, that's a key for ideal health. Physical activity is point number 2. Managing your blood pressure and your cholesterol are points 3 and 4. Blood sugar, 0.5. 6 is eating better, and 7 is controlling your weight. So really, these are the 7 pillars of health. And again, less than 1% of Americans achieve A+ in each of those areas. So I think we all see now that we have some work to do. And my goal today is that when you walk out that beautiful door into a lovely summer evening, some aspect of your life will change, and that you will have a transformation in your health and really have a benefit from attending this amazing session. Smoking, as we know, is really the most preventable cause of cardiovascular disease. If you smoke, do your best to quit. Ask your healthcare team for assistance. There are a number of very effective methods of smoking cessation that exist today. More importantly, if your loved one, children, siblings, or parents smoke, talk to them. We realize that smoking is such an important risk factor because we can completely reverse some of the effects of cardiovascular disease by smoking. One of the areas that women don't think about is the young smoker. Smoking and taking birth control pills increases your risk of stroke by 20 times. So if you're young, if you take oral contraception, birth control pills, you should not smoke. Again, listen and think. Think if you know one person that smokes, and think if by just gently working on them slowly over time, you can help them quit. Big step. Physical activity. Now you're all lucky because you live in such a wonderful place. As you heard, I took great advantage of Nantucket yesterday, getting outside. But you don't have to do a lot of physical activity to actually meet the current recommendation, which is 2.5 hours per week of vigorous physical activity. Now that can be done in as little as 10 minutes per session. And activity does not mean that you have to run or that you have to cycle. It can mean that you're briskly walking, or that you're gardening and you're actually getting your heart rate up, or that you're taking the stairs more often and that you're doing that many times a day and counting those steps up to 10,000. But really that goal is 2.5 hours per week. And if you think about 2.5 hours per week, we all have that kind of time we can build into our schedule, even if it means getting up a little bit earlier or doing it at lunchtime. It's so important. Some of the clues and some of the tips that I have are find someone that you can partner with. You know, there's been this significant increase in organizations that recognize the power of a group things like CrossFit, things like Get in Shape for Women, and organizations that allow you to exercise with other people, or a Pilates class or a yoga class where you can go and see people, and if you're not there, they'll ask why you weren't there. That kind of accountability is so important, and it helps you get into a pattern of good health. Also, if you're going to start something like walking, running, jogging briskly, talk to your doctor and make sure that it's okay for you to start that type of activity without having to have any type of screening test. Most people are fine to do that. But if you do have high blood pressure, you might want your blood pressure to be checked carefully before you start vigorous physical activity. One study that was done early in the 1970s actually showed that if you do something regularly for 18 times in a row, that it will become a habit. And that doesn't necessarily mean 18 days in a row. That just means if you exercise every other day, if you do it for 18 times, that habit will stick. And then when you don't do it, that little light bulb will go off in your brain and it will say, whoops, you need to get those sneakers on and get outside. Managing blood pressure is incredibly important also because high blood pressure is treatable. It's the silent killer. If it's left untreated, it can cause heart failure, heart attacks, and strokes. And this is something that's so easy to treat. The blood pressure numbers and the goals have changed. As with everything in medicine, things go up, things go down. But right now, the goal, if you're under 60, is to have blood pressure under 140 over 90, 80 to 90. If you're over 60, we actually allow the blood pressure to be a little higher, which is 150 over 90 or below. The issue is if you're over 60, many of the blood pressure medications have side effects that make you lightheaded and dizzy and prone to falling. And so we're a little bit more lenient with 60 and over. However, if you have kidney disease or heart disease or other vascular disease, we're going to shoot for even lower, such as 130 over 80. So this is a very individual target depending on your overall health. Certainly we want everyone to live around 130 over 80. Those numbers that I told you are the numbers that we use to start medication. Now, before we start medication, the first thing I tell all my patients is that you need to exercise if you're not exercising. We know that exercise helps reduce blood pressure. So does reducing sodium in your diet. Less than 1.5 grams or 1,500 milligrams per day is the current recommendation. And the FDA has made it easier now. If you look at a bag of potato chips, it doesn't tell you how much salt is in per serving, which that's really misleading. So you can see the bag and it will say 100 calories per serving, but the bag has 3 servings. Not a good idea. It now tells you how many in the bag. So if you're gonna eat the bag, how many grams of sodium, how many calories, etc. Just so we're well informed. The other thing is alcohol. So excessive alcohol use can really drive up blood pressure, particularly in postmenopausal women. So we want to stick with that recommendation. It's a tough one sometimes, but that 1 glass a day is considered moderation. For women, guys get 2 glasses, 1 glass of wine, 1 drink. But that's per week, so that's 7 days in a week, so you figure it out. But that's the current recommendation. And the healthy diet is so key. Now, cholesterol is another risk that's very important. We know controlling cholesterol is something that will reduce our cardiovascular risk. These numbers are also a moving target. Those of you that are physicians in the audience know how frustrating this can be. I do it in an individual way. I talk to my patient, I find out their family history, I look at their numbers. I try to get them to exercise, modify their diet. But if there are substantial risk factors present, we talk about therapy. And of course, statins are the most commonly prescribed medication. In women that are premenopausal, we often will not use them unless there's a strong family history or substantially elevated cholesterol. The numbers you need to know: LDL, low density lipoprotein, that's one of the fractions, that's the one that is tied to cardiovascular risk increasing when it's higher. HDL is the good cholesterol, small little particles that go around and scrub your blood vessels and clean out cholesterol. You want that as high as it can be. Women are lucky, our HDL numbers are a little bit higher than those of men. And you want your total cholesterol number too. As well, we usually want to aim for under 200. However, if you're a lucky person and your HDL is very high, you may have cholesterol a little bit over 200. Again, it's very individualized. What I do in my practice is I plug the numbers into an algorithm that's available on the computer, and I tell a woman her risk and 10 years of heart disease, and we, as a pair, patient and doctor, decide whether or not they want to take, she wants to take a statin. And we talk about risks and benefits, and it's always, erring in the side or going towards the area where we have the highest benefit at the lowest risk, and whatever that is. They're also new, the shot for cholesterol is now out, Repatha. It's very expensive. The drug companies would like us to use it in everyone. We reserve it primarily right now, we reserve it for people that are statin intolerant and really need to take a statin. Again, know these numbers, cholesterol numbers. Blood sugar, diabetes is an epidemic in the United States. Children born after the year 2000 have a 1 in 5, 20% chance of developing diabetes in their lifetime. Pretty profound. We need to change this. This is a combination of inactivity and poor diet that leads to diabetes. We also know that stress increases the risk of diabetes because our body creates more, increases our cortisol levels. It puts our pancreas under stress. Our pancreas doesn't allow insulin to work as well. It doesn't release the right type of insulin. So again, also something we can completely manage in many people with diet and exercise. And those can really work in our favor to bring down that hemoglobin A1C, that number. We like it under 6.1. And if you are a diabetic, of course, it may be a little higher, but there are a number of new medications that can certainly help reduce that. Know your hemoglobin A1C, know your blood sugar. That's one of the 7 things you need to always be aware of. And your doctor can check that when you go for your visit. Nutrition is such an important thing. Now, this is something we really have total control over. And in the audience, we have the people that buy the groceries for the family. So mom really has control over her family's nutrition. We know that that research that's being done that looks at family nutrition, you start with mom, you educate mom, and everyone wins, which is such a great thing. The dietary recommendations have been relatively solid. They haven't changed as much as blood pressure numbers and things like that. The current recommendations are eating 5 to 7, if not more, fruits and vegetable servings per day. If you eat products that are grains, shoot for the whole grain products. Avoid the bleached starches, such as bleached flour. Fat-free and low-fat dairy products are helpful, but you have to be careful because there's a little bit of a marketing gimmick going on here, where the fat-free yogurt has twice, in some cases, the amount of sugar as a non-fat-free yogurt. And sugar is not our friend, so you need to look at the label and see how much of fat and sugar is contained within products when you purchase them. We encourage the intake of fresh fish, which is abundant in Nantucket, and especially fish that contains omega-3s, such as salmon. We really strongly believe in, when I say we, I think the medical collective really believes that sodas are really not our friends. Even diet sodas are linked to increased risk of diabetes, probably because people eat the wrong things when they drink the diet sodas, but we're not sure. So stick to water, tea, other choices. Juices, you have to be careful because some of them have a lot of added and natural sugar again. So you want to look at that. Finally, again, salt, I mentioned that earlier when we talked about high blood pressure, but look at those labels. Shoot for less than 1,500 milligrams per day of sodium. And again, I think one of the things that's so important is to think about what your family eats, what they like, and try to create, meals that people will enjoy that are also low sodium and low fat. Very important. Obesity, yet another epidemic in the United States. 1 in 3 Americans is obese. That is the new data. And that is up to 40% of Americans if you look in the southern 9 states that we consider the red zone. Really big issue. And I think one of the things, if you look at the map, which I normally include this map that's a color-coded map, it kind of looks like what we see in November, the blue and the red. But actually it looks at obesity by state, and Massachusetts has always done very well. Actually, I think we're only second to Colorado and Utah as far as the lower obesity prevalence. But one of the things that we've seen that in the year 1996, there was just a robust increase in obesity prevalence. Why do you think that was? 1996. What started in 1994? The internet, right? So people now sit and spend a lot of time. They don't write letters, they don't get up and walk to the mailbox, they send an email. You can order everything you want online from Amazon, so people don't go to the stores anymore. And I think this has had a profound impact. Inactivity and poor diet are the key demons as far as I see in our behavior and really are hurting our health and our children's health. So it's so important that we teach our kids and teach our family members to get up, to move around, and really limit that screen time if possible. For weight, for BMI, we're shooting for under 25. That's the goal. It's important to know yours and then to talk to your doctor about a plan to get your BMI where it needs to be by, again, activity and appropriate diet. So the My Life Check really summarizes these 7 components that I've talked about. You can find it online through myamericanheart.org. I'll show you the website in just a second. Now, you can print this and take it with you to your doctor's appointment, and you can blame it on me and say, Dr. Wood, Melissa said I should have these things checked, and I think I need to. Because what we found is that many physicians are very busy checking boxes and working on the electronic health record, and docs are pretty good at ordering mammograms, pap smears for women, not so good at looking at cardiovascular risk. And so you can just gently remind your physician that they should help you look at your cardiovascular risk. Plug in these numbers once you have the data available, and it will tell you where you fare. But the good news is, even if you don't do so well, you can change it, right? We've talked about the things you can do to change. This is the website, Life Simple 7. Now I know Dr. Denninger is going to really talk a lot about resiliency, but I have to once again put this plug in as well, because I strongly believe that I see this every day in my practice, that emotional health issues really drive poor health choices. People with emotional issues are not sleeping as well, they're not eating as well, they're drinking too much. If they smoke, they're smoking too much. So recognize if you're suffering from emotional issues such as depression, anxiety, or just you have a lot of stress in your life, and try to find healthy ways of dealing with it. We know that stress can be a good thing. And I remember when I was just starting my first job as a cardiologist, and I trained as an interventional cardiologist, so I used to do stenting and angioplasties. And I was in San Antonio. I was sitting on a 4th of July float. There was a parade in our neighborhood, and I was sitting next to Eileen Collins, who was the first female space shuttle pilot. And I was like, oh my gosh, I can't even imagine flying a space shuttle. I would be so afraid. And she goes, I can't imagine she goes, I can't see blood. I see blood and I want to pass out. And and it was like what she thought was stressful, I did every day, and vice versa. And I think, stress can motivate us and drive us and help us achieve success, but it can be our worst enemy. So when it's there and it helps you, be thankful that you respond to it, but try not to be perfect and try to manage your stress a little bit better if you can. The relationship part, so important. Again, I really want to stress the connectivity piece. If you want to change something in your life, one of the behaviors we talked about, find people who do that regularly and hang out with them, spend time with them. If you feel like your mood is a little down, try spending time with people that make you feel happy and doing things that are positive, and really utilize and leverage the power of your social connections. Research has shown that it's so important to be able to do that to really improve behavior. So look around, find people that do things that you think are important and spend time with them. Look at the women in this room. There's got to be someone here that that can help improve your health. Environment, I just want to stress this because it's something that I think medical professionals forget. If you live in a messy, dark, unhappy place, that's going to affect your health substantially, and we know that. Regulating the light in your life, even people that work night shifts, if they regulate their light, even though it's the opposite of what everybody else is experiencing, their sleep is much improved. Poor sleep is one of the strongest predictors of poor health. So we want to do everything we can to improve the natural light, add some green, make our home and our environment more healthy. Finally, I'm sure I'm probably running close to out of time, communication. Now, whether this is communication with your family, your friends, or yourself through journaling, it's really important that you take the time to record thoughts and to share your thoughts with other people and not bottle things up inside. One of the most common personality traits I see amongst my young patients who have heart disease is they have that type A need for control, but unable to tell people how they feel. It's okay to be type A. I know a few people like that, and it's okay to need control. But when you bottle things up inside, it has a profoundly detrimental effect on your health. So learn to journal. It takes time, just like learning to meditate. But you can help improve your own health through doing that. Now, I did say I'd talk a little bit about communicating with your healthcare professional, and I think that's a really important piece. So I cannot tell you how many times I've spent 30 minutes with a patient and I've asked them the questions and we've talked about things, and they're walking out the door, and then they're like, well, I have some chest pain. And so then the visit starts from scratch. And the truth is, when you walk into a doctor or a nurse practitioner's, space, you probably will have their attention for about the first 5 minutes to 10 minutes, because then they're busy documenting, doing your prescription, doing the note. And unfortunately, electronic records have sort of forced doctors into some of these patterns. Even the most well-intentioned doctors and nurse practitioners and PAs have this habit. So you need to get them while they're paying attention. Bring a list of questions, bring a list of symptoms, bring someone with you. That is so important. If you can bring someone with you and you're going to be talking about something that's important, it is really key to have someone there keeping a track and taking notes, because you may not remember the things the doctor says, even if you have a perfect memory, which of course we all do, right? Especially after menopause. But I think one of the things is that when you're nervous, you do not remember the things that may be said. So if it's something important, bring someone with you to record it. And really work on fostering that patient-doctor relationship. We are now teaching in medical school. We're teaching the doctors and nurses how to learn to communicate better, because we realize that is the key to excellent care, is communication. And it goes both ways. So finally, women are at risk of heart disease. Women can modify their risks for heart disease substantially. And in fact, women have more of an opportunity to change their risks than men. But it's a lifelong approach. It's never too late to start. I've given you the 7 areas in which you really need to focus. It's important to recognize new symptoms should they occur and have them checked out. And if you are trying to have your symptoms checked out and you don't feel like your voice is being heard, then just keep going. Go to the next person. Because oftentimes healthcare professionals still don't recognize that women are at risk of heart disease to the extent that they are, and they may have sort of a judgment bias. And so if you feel something's wrong, keep pushing until you get an answer. Don't ever be afraid to call 911 or go to the emergency room if you think something's wrong. That call could save your life, so be sure to pay attention to new symptoms. Know your risks and your numbers, and engage your friends and family, because they can really help motivate you and help improve your overall health. Know your numbers and tell a friend. This is my daughter and I. She ran across the finish line with me in 2011 when I ran Boston, and she also ran across the finish line with me when she was 3 in 2001. And so I love this picture. So thank you very much for your time.
Thank you so much, Martha. That was fascinating. I think many of us in this room might be a little sad. We're going to have to kick our juice bar habits this summer.
Oh, I heard about the juice bar ice cream.
Anyway, we'd like to kick off Q&A. How we're going to do this is we're going to have a time after each doctor, and then we'll have a little bit of time at the end. And if you don't get your question answered, the doctors will be here afterwards too, so you can ask them personally. So we want to make sure everybody is heard in this room, so you will get a chance. So right now we're going to have Jason walk around with a microphone. And please raise your hand if you have a question for Dr. Wood.
There's one over there. There's a question right there.
Dr. Wood, I have heard that after the first alcoholic beverage, when you have a second, you increase your risk for cancer. And your risk for cancer increases with each drink. Is that accurate?
There has been some, oh wait, my little friend here, sorry. There definitely is an increased risk of breast cancer with excessive alcohol intake, unfortunately. And I haven't heard the specific that after that first drink, but I do know that the more one drinks, the higher that risk, whether for primary breast cancer or for recurrent breast cancer. And I think that that's probably a pretty good estimation, because it really allows people to cut off. You really think about that first drink. So I think it's important. But that exact number of 1 to 2, I haven't. What number is excessive? Well, I mean, as a card-carrying official of the American Heart Association, I can tell you what we say is 7 drinks per week. So it's 1 per day. And, I think above that, the risk of blood pressure elevation increases. So that's the recommendation.
EKG to be important to have during your yearly physical?
I do not unless you have had a new cardiac symptom. So if you've reported to your doctor that you've experienced palpitations or rapid beats of the heart, chest pain, shortness of breath, any type of cardiac symptom that's new, it should be done. It is an imprint of your heart's, electrical pattern, and it's very helpful in looking at some conditions. Now, if you said you'd had chest pain and you're not having it when the EKG is done, a normal EKG doesn't really exonerate heart problems. It's just a good way of screening for changes that could be associated with chest pain. But again, new symptoms, definitely. Otherwise, routinely, we don't do them in internal medicine practices, but as a cardiologist, anyone coming to see me, of course, will have one because it's part of your cardiovascular profile.
Why are statins not recommended for premenopausal?
They have risks with pregnancy. So if a woman is premenopausal and has had her tubes tied, or has had a hysterectomy, or is safely using contraception, then they're fine. It's really the risk of problems if a woman becomes pregnant and takes the statin, and that's the main reason. And also the risk of cardiovascular disease in menopausal women is so low for the traditional atherosclerotic type that the risk benefit really isn't routinely in that weighing towards using it unless there's a strong family history, a really bad lipid profile, or other like chronic kidney disease or known cardiovascular disease.
At what age do you think it's important for us as parents to know the numbers for our children? What is it, young adults?
So that's a great question, and that number is becoming, it's really lower and lower now. I think routinely pediatricians, and I don't know the AAP guidelines, but I know that routinely they will check it after age 12. And if there's a family history of a strong risk for cardiovascular disease, or mom or dad have very high cholesterol, they may check it before. Unfortunately, many young children are now on medication for blood pressure and for high cholesterol because of the obesity and poor diet. And so blood pressure is also important. And of course, that's checked in every visit. But I think you again, individualize, but after 12, they routinely will check it once.
Jason, can we do one more?
One more question. And then I'll be around, so feel free afterwards.
Okay,
Yeah.
we heard.
I just had a question about statins.
Mhm.
I had high cholesterol and was told for years not to be on the statin because I had very high HDL.
Mhm.
And then all of a sudden, 1 year, my doctor said, oh no, they've done studies and now we feel you should be on statins. And then I had a friend who's a physician say, oh, you should never be on a statin.
I will apologize right now for all of the confusing information that's out there because it is confusing. If we find it confusing, I can only imagine for patients how confusing these statin issues are. Statins clearly reduce the risk of stroke and heart attack when appropriately used. And the determination is based right now on this algorithm, this formula that we use that looks at things like your gender, your cholesterol number, your blood pressure number, whether or not you smoke, and whether or not you have diabetes. And did I say age? So it includes all of those factors, and that will give us a number. And if your risk of a cardiac event in 10 years is over 6.5%, your doctor will encourage you to take a statin. And so it has changed. The guidelines changed in 2013 and really turned us all upside down because we were using statins to get to numbers like we want your LDL below 100 or we want it below 80. And now it's like high intensity statin if your risk is high. If your risk is not high, you can use a low intensity statin, which has a lower risk of side effects and smaller risk of diabetes that is known to happen in some statin use. So it's confusing, but again, I believe in personalized healthcare. Every patient has, and their doctor should make a decision together knowing the facts. And after, I'm happy to, she really seems like she wants to ask a question.
Because there was a program, there was a Cleveland clinic, this was several years ago, with a group of cardiologists, and we were talking how important it was to have a
C-reactive protein.
Yeah, and
Right.
so I had one internist who was happy to do it, and then I got no way as a reaction to other doctors. So is this a good, so is this a good test?
So
If you're at a risk or you have family history of heart?
So C-reactive protein is not included in the guideline for determining use of statins. I use C-reactive protein when someone meets the guideline and doesn't want to take the statin, and I say, I really think you should, but they don't want to, then I'll say, well, what if I can show you that there's an elevated inflammatory marker? Because there's sort of this relationship between C-reactive protein and cardiovascular disease, but C-reactive protein is very nonspecific. If you've had a cold, if you have arthritis, if you've had an infection, a urinary tract infection, C-reactive protein can be very, very high. And in fact, it can go up and then come right back down. So I don't use it in general to make the decision about a statin, but it does help if there's either if it's ambiguous or unclear if you should take a statin, or if you don't want to and your doctor really wants to push you towards it. The decision to choose a statin should be very, very clear based on using that algorithm that I mentioned. So I don't use C-reactive protein overall in most patients.
Thank you so
much for that.
Putting it very high up. Can you hear me or not? Terrific. It is an absolute pleasure to be here today. I couldn't begin without first thanking Meryl, Melanie, as you for their extraordinary welcome and enthusiasm for this program, the host committee, and of course those folks at Nantucket Cottage Hospital. It's also incredibly organized. And it's a wonderful two-page agenda with all of the wonderful things that you do on your island, and it's just been a lot of fun for the people. So thanks so much. I have the pleasure today of speaking to you about optimizing teaching. Everything you wanted to know about sex, but were afraid to ask. And there will be time for questions. So as everyone in this group well knows, sexuality is very complex. Those of us in medicine are very comfortable with physiology. But you cannot address a sexual problem without also thinking about psychology, interpersonal relationships, and sociocultural influences. When we think of sexual problems, we tend to group them into four major areas: desire, arousal, orgasm, and pain. And when those problems are associated with distress, they not only become problems, they actually become what we call disorders or medical disorders. We often hear in the lay press and literature, 50% of women have sexual disorders. And I remember hearing that about 15, 20 years ago and saying, wait a minute, if 50% of us have it, it's not a disorder, it's normative. So we better be careful about how we're defining these problems. So we did a really wonderful study in 50,000 women from ages 18 with no upper limit of age. And we sent them questionnaires and asked, do you have the following sexual problems? So for instance, the slide I'll show you was on low libido. That is the most common sexual complaint for women. But we also asked them, is that distressing to you? So what we found, if you look at the blue bars, is that low libido is very high for women. It's about 20% on average, easily about 50% at midlife, and in women over 65, well over 50%. But the important question is that bothering you? And the good news is that's the yellow bars here, and you can see the number of women who are really bothered by a sexual problem is much lower. Now, we do see that peaks at midlife. That is the age at which women both experience it and are bothered by it. So I think it's really important to realize sexual problems are incredibly normative. You know, you just came home with your new baby and you're about to go back to work, and that is normative, and we shouldn't be pathologizing that. On the other hand, if everything seems right but there's low libido that's really distressing to someone, we need to be taking that very seriously. At the end of the day, about 12% of women still have a distressing sexual problem, and most clinicians don't ask, and most of our patients don't tell us. So
even if your clinician doesn't ask, do share that information. It's important, and there are treatment options. It's very important to realize that interest in sex and the importance of it does not end over 60. This is a beautiful study in about 3,000 men and women between about the ages of 57 and 85. And what they found is that the majority of older adults in intimate relationships, and they really do regard sexuality as an important part of life. And then, unfortunately, the impact on age on the availability of a partner is really the #1 reason why a lot of older women are not active. We call it the partner gap. And about 40% of women, only 40% of women over 75 actually have a spouse or intimate relationship, and that number is much higher for men. So important to realize that that's part of the problem. Well, what about distress? So what are the predictors of distress in your sex life? You know, those of us in medicine wanted to think, well, it's a problem with arousal or lubrication or orgasm, and actually, I really love this study. If you don't remember much else today, please remember this. The most important predictors of distress associated with a sexual problem are your general well-being, your emotional relationship with your partner. So if you want to step back and think, how can I make my sex life better? Just think about improving your overall general physical and psychological health and working on your relationship. We could stop there, but I'll keep going. Well, what are some factors that affect sexuality? So clearly, interpersonal relationships are key, and that's relationship quality and conflict, as well as partner performance and technique. As women age, their partners age, and things can happen for men as well. For instance, erectile dysfunction, which is actually quite easy to treat. So do be open with your partners if there are things that they could do that will make things more interesting or pleasurable for you. Talk about it. Communication is really critical to optimizing sexual well-being. And we'll talk about a lot of these things more, but depression, anxiety, history of abuse, antidepressant use, substance use disorders, and body image issues, weight, fitness, are really important in terms of healthy sexuality as well. Sociocultural influences are very important. I always put stress and fatigue at the top of the list. One of the first questions I ask couples or women when I'm taking a sexual history, tell me about the last time that you took time away together without family. And I've actually had couples argue about whether it was 3 years or 5 years ago that when they went to Disney with the in-laws, and I'm like, you just answered the question. Lack of privacy is important. A simple lock on a door, teenagers in the house, can be really important in terms of improving sexuality. Inadequate education, and also there are important cultural and religious concerns. We'll be spending a reasonable amount of time on physiology. There can be medical and neurologic problems, gynecologic and urologic problems, and then we'll talk about hormone deficiencies as well. As far as treatments, I will really be focusing on this for the rest of the talk, but of course we need to focus on relationships. Counseling can be very effective. I'll talk a little bit about sex therapy, education. Treating depression and anxiety are incredibly important, really fits right into our cardiology talk. On the other hand, we have to be very careful about the medications we use because, for instance, SSRIs can be a major cause of low libido and anorgasmia for women. And then body image is really important. That fits in with our cardiology talk as well. Sociocultural influences, reduction in stress, improving, reducing fatigue, improving privacy can make a really big difference. And we'll talk a lot more about some physiologic interventions as well. So as far as psychotherapy, counseling, sex therapy, these are very effective interventions. In my clinical practice, I actually have a rule that I will not give a prescription unless a couple, or at least the woman, who's typically my patient, has taken a little bit of time to either see a sex therapist or a counselor, because no matter what else may be going on, it is always helpful. So really keep that at the back of your mind. They can help couples deal with relationship conflict, major life stressors, discrepant levels of desire. If one partner has low desire and one partner has high desire, low desire in that situation is not a sexual disorder. It's a time for that couple to come together, talk about how they can work through those discrepant levels of desire, compromises they both can make, and then improving communication around sexuality. We'll talk a little bit more about treating depression, anxiety, body image issues. There's a fascinating thing that sex therapists do called sensate focus exercises, where literally they will have a couple come and they'll give them a schedule. Week 1, I want the two of you to go home and for 5 minutes or 10 minutes each evening, provide each other with a little bit of pleasure in non-sexual areas. May that be scalp, toes, hands, and then the next week they come back and the goal is to maybe try something that's in a sexual area, and they really save going back to what we traditionally think of as satisfying sex, orgasm or penetration, and at the end of several weeks of sensate focus. Start thinking about, what does that do? Why is that helpful? It gets couples to focus on intimacy, pleasure, communication, and not just, was it perfect and was it at the same time? And that's really important. So you can start to think about, what is my definition of satisfying sex? And what should that be for my partner? And how can we come to terms with really making it more satisfying for both of us? And so sensate focus exercises are great. I suspect you have a sex therapist on the island. You just have to find him or her. But there are a lot of great books as well. Education is incredibly important. We'll talk a little bit more about novelty, but that's really important too. I love this slide. It says, I was on hormone replacement therapy for 2 years before I realized that what I really needed was Steve replacement. Now, we have a few brave men in the audience, and I am not advising you to replace Steve. What I'm really encouraging you to do is think about how you can make Steve more like the Steve you knew 20 years ago. And often I'll say to a couple, you know, hey, think about what you two did that was really fun and pleasurable 20 years ago. And I see some smiles and I see some winks. And so a lot of it is just really taking time to kind of recreate some of the stuff that happens early in relationships, that we get busy with kids and work and taking care of elderly parents and all of the stresses, and we kind of forget about what we really spent time on in the beginning that really made relationships fun. So what about bibliotherapy? Very effective. I would love to send you all, if you Google menopause.org, that is the North American Menopause website. We have a wonderful sexual health and menopause program that I did with a great sex therapist in Boston, and it's really helpful. Feel free to have your partners look at it as well. I actually have kept 50 Shades of Grey on the list because I had this wonderful couple who came back, and we'd given them lots of suggestions for things to do, and they said, you know, Dr. Schifrin, you gave us a lot of great suggestions. Every Saturday night, we read a chapter, exciting novel, no problem. So I've kept it on the list. There's a lot of great books. I used to say go to your local bookstore or go to a bookstore in a neighborhood where you don't live, so maybe when you're off island. There are only 2 bookstores here. I bet they actually have some great books on sexuality, but you'll have to wear your dark glasses, your floppy hat, and hope you don't bump into your many wonderful neighbors. But there are a lot of great books, and I really do encourage you to find a book that works for you, works for your partner. There's another great website, aasect.org. Keep it simple. If you Google sextherapy.org, make sure you don't get .com. But .org will actually bring you to a great website. And I wouldn't be surprised at all if maybe on the Cape, if you have to go off island, but even here on the Cape, you may have a certified sex therapist. They are great. And if you can't get your partner to go, and often it's tricky, I usually encourage women to go first, make sure it's going to be a good relationship, and then if they can, bring their partner. I had a wonderful couple. The woman said, I cannot get my partner to go. Oh, I remember what she said. She said, you know what? I could never get my husband into counseling, although I knew we needed it. But when I told him it was about sex, he signed up. And she said, you know, we really, the first few visits, we talked a lot about sex. All the other visits, we've been talking about financial stresses, we've been talking about our elderly parents, we've been talking about the problems we're having, you know, with our adolescent daughter, and guess what? The sex got better. So it's a really good lesson. If you can get a partner there, it makes a big difference. I put yoga on the list. We've talked a little bit about yoga today. A wonderful study where women were enrolled in a yoga program, and they did a validated questionnaire on female sexual function before and after yoga, and guess what? Significant improvements in all domains of sexuality. So I think that attests to feeling better about your body, being a little more creative, having some confidence. So another great reason, and I think you have terrific yoga instructors on this island. Very lucky. Well, what about some wait, let me just see what I want to cover. Let's see. Did want to definitely talk about vaginal dryness and changes. We'll talk about that a little bit more. But you know what? Without even needing a prescription, what are some things you can do? Even at the CVS on island, or I think it's a really adorable local pharmacy that's not a CVS, I am absolutely sure that they'll have some lubricants and moisturizers. These are things you can buy over the counter. They're very effective. They're very inexpensive. There's some that are zesty. So if you have any dryness at all, really have a low threshold to purchase these products. What I always say is just thinking about it, going to the pharmacy, buying it, and putting it at the bedside is actually already going to make things a little bit more interesting. Lots of brands, find the ones you like. What about devices? There was a lovely study that showed that this is a device similar to men. Men with erectile dysfunction, before we had the very effective drugs like Viagra, use these little vacuum devices, battery operated and things, and increased blood flow to the penis, which is really all that the ED drugs do. And so someone designed one for women, and it does the same thing. It kind of increases blood flow to the clitoris. And so this is really no longer available. It was extraordinarily expensive. Devices aren't covered by insurance, but I use it as a reminder that if it is in your comfort zone, devices have really been shown to increase sexual pleasure for women. Things like vibrators, they can be both not partnered or partnered. They're very inexpensive, easy to use, and believe it or not, they're even sold at CVS in the same section where you can buy lubricants and moisturizers. So if it's in your comfort zone, they really can be very effective and helpful. Well, what about what we call the genitourinary syndrome of menopause, which is also known as something called vulvovaginal atrophy? And that's the dryness that women typically experience with the estrogen deficiency of menopause. And what we know is about 50% of postmenopausal women will have bothersome symptoms associated with vaginal dryness, discomfort. But what I find incredibly sad is that when we do big studies, only 6 to 7% of women in this country are effectively treated. And there are many effective treatments. So what are some of those effective treatments? The lubricants and moisturizers that I talked to you about. Again, those can be used by premenopausal women with dryness as well, but very effective postmenopause. But if the lubricants and moisturizers aren't doing the trick, there are incredibly safe prescription products that are very, very low doses of natural estrogens. And they're FDA approved, they're estradiol. And what's great about these products is that they don't bump your blood levels of estrogen. One is a ring that you place in the vagina called Estring, leave it in for 3 months, and kind of just like that Brita filter, put it on the same schedule every 3 months, pull it out, put in a new one. It works incredibly well. And because it's there all the time, you can just forget about it, and yet have very effective treatment of the postmenopause vaginal dryness. There's another little tablet called Vagifem. You just put it in the vagina twice weekly with either a finger or applicator. And then there are very effective creams. Most women don't like those because they're a little bit messy. You put them in an applicator and use them 2 or 3 times a week. All of these products are equally effective. It's really just the one that you prefer. When we measure blood levels in women using these products, they don't bump. So this is the one time that I actually tell women not to look at the package insert for their medication. I usually encourage women to be really well informed. We at the Menopause Society are actually working with the FDA to try to change the package insert. It is exactly the same package insert you would have if you took high levels of estrogen that raise blood levels to treat hot flashes. The incredibly low doses that are in these products that treat vaginal dryness very effectively do not raise blood levels. So there's no way they can cause heart disease or stroke or breast cancer. We even use them in women with breast cancer. We use them in women with heart disease. We use them in women with leg and lung clots because they're so safe and they're really underused. So feel free to speak to your clinician about them if those are symptoms you have that are not relieved by just lubricants or moisturizers. I should also point out, in a few moments. Well, what about other pharmacologic treatments for sexual problems? There was a lot of excitement about using the Viagra-like drugs in women, and very large studies were done. The highest quality study, we call them double-blind, meaning there's a placebo, and neither the clinician or the patient knows what they're getting. And the exciting news is Viagra treats low libido and sexual problems for women. But guess what? The placebo tablets work just as well. So, placebos work for everything. They even work for high blood pressure. So placebos are terrific, and we shouldn't undermine them. On the other hand, we shouldn't be taking drugs with potential risks that are also quite costly that really are probably no better than placebos. Occasionally I have a patient who says, Dr. Schifrin, I know you've told me it's no better than a sugar pill, but I really want to try it. It works so well for my husband. Well, I give a prescription for a few tablets, and I think one reason that the placebo effect is so high is it's about $60 a tablet. Look, you paid $60. Things are likely to get a little bit better. And so when she came back, I said, well, what do you think? How did it work? She said, Dr. Schifrin, it was the first time I had a terrible headache after sex. So they're not without risk. They cause terrible headaches. They're very costly, so I wouldn't waste your money. But it is a reminder that placebos work. Well, what about antidepressant use? Things like SSRI. So depression is one of the biggest predictors of low libido with distress. So if you have depressed mood, see a healthcare provider, get treatment. On the other hand, let that healthcare provider know that you might also have some problems with sexual function, or if you develop them after treatment. Because the most commonly prescribed drugs for depression are things like SSRIs. They're really effective, but for a lot of women, they have sexual side effects. So there are some drugs. The one that we most commonly use for women with sexual side effects with SSRIs is called Wellbutrin, is a trade name. Its real term is bupropion. And that can really be a drug that can treat depression without sexual side effects. But again, again, you'll have to talk to your clinician to make sure you're finding something that's effective and safe for you. There's actually a really lovely study of using bupropion or Wellbutrin in young premenopausal women, but I assume it would work just as well in postmenopausal women with low libido who didn't have depression. And what they saw were statistically significant improvements in many aspects of sexual function greater than placebo. So occasionally, everyone wants a drug, right? It's a lot easier to take a tablet than change your life. And if someone has really done a lot to change their life and they're still having distressing low libido, this is typically one of the things I might prescribe. Relatively safe, FDA approved for depression and smoking cessation, off-label for treating low libido, but probably more effective than placebo. But certainly if you're on an SSRI and having some sexual side effects, talk to your clinician about a switch. There is one FDA-approved drug for low libido in women. Has anyone ever heard about flibanserin? It's actually been out for about a year. So I think the reason you haven't heard about it is FDA-approved for premenopausal women, but we studied it in postmenopausal women. It had equal efficacy. And at the end of the day, it is, of course, costly. You are not allowed to drink anything while you take it because it can cause dizziness, somnolence, all of which may get worse, fatigue, dizziness when you're drinking. And so I think for a lot of couples, alcohol and sex go together, and so this really isn't a very nice thing you can't do when you're taking it. The other thing I really like to point out is, if we look at the percent of women with a meaningful benefit from this study medication, it was about 38%. Now that sounds pretty good, doesn't it? Women who took placebo had a meaningful benefit of 28%. So is it worth taking something that's costly, has side effects, can't drink, for a 10% greater chance of having a meaningful benefit? I think most women, when they really do the risk-benefit calculation, say no. But it's out there, it's FDA approved. Well, what about androgens, testosterone? That's really where I really got interested in this field. I've done a lot of research in androgens for women. And what we know is that essentially anyone in this room who is 50 and above has a low testosterone level. It declines with aging. It doesn't specifically change with menopause. So if your sex life was pretty good before menopause and now you're having hot flashes, sleep disruption, fatigue, and vaginal dryness, and you come in with low libido, it's not your testosterone. And actually by taking in that situation probably systemic estrogens, treating a lot of the side effects of menopause, you are likely to just have an improved sex life because you're feeling better. But every woman 50 or above has a low testosterone level. Well, is that associated with low libido? I think the best study out there really showed that testosterone levels or free testosterone index really doesn't predict sexual function in large populations of women. Guess what? The principal predictors of sexual response were not your testosterone level, but your feelings for your partner, change in partner status, which is actually a very polite way of saying a new Steve. Prior level of sexual function, if it was good before, it's likely to be good after, and estradiol level. And that's probably because if you're having hot flashes and vaginal dryness, you are not going to be interested in sex. But the treatment then will be talking to your clinician about the safe use of estrogens, not androgens. Well, there are some studies that if you give very high doses of testosterone, just as an aside, the name of this product was called Climacteron. You will have improvements in sexual function. So there's no doubt that androgens can work. But I would like to point out that at the point that they're really working to improve desire, fantasies, arousal, and response, they are in the low male range. And that is certainly not something that is healthy or that women want. So what we did is over a series of about 10 years, we did a very large study of double-blind, so we used a placebo, studies of something called the testosterone patch. And the goal was to take postmenopausal women, we studied both naturally and surgically postmenopausal women, and raise their testosterone levels from where they are when you're older or you've had your ovaries removed, where they drop half, to about where they would be when you were in your 20s or 30s. So it wasn't in the low male range, but the upper limit of normal for women in their reproductive years. And what we found was that the first thing I like to point out is if you look at the blue bars, placebo patches work. So that's really, I think, a testament to mind over body. And you'll hear from Dr. Denninger next. But the testosterone patches were more effective than the placebo patches. I'd like to point out that the significant improvements above placebo were small, and that these were very carefully selected women. You know, all of them said they had great relationships, they had no vaginal dryness, they had no depression or antidepressants. So, you know, we had to screen about 100 women to find one who qualified. So I think if you did all of the things that you need to do for qualify for the study, you probably wouldn't need it. Another product was then, this was not approved by the FDA because they basically said, well, maybe we'll give you efficacy, but show us long-term safety. And the take-home message is we have no long-term safety data on androgens for women. So, you know, we are concerned about long-term uses of estrogens, things like heart disease or breast cancer in long-term use. Short-term use is quite safe. And so there could be those same concerns with androgens. So another company said, well, we'll do a long-term safety study, and we'll match the efficacy study, but we'll use a gel. And guess what? They broke the study blind, and even though they had the same levels of testosterone that we got with the patch, the placebo response was so high, they saw absolutely no difference between testosterone gel and placebo. So there may be an effect, but if it's there, it's small. And this will probably never be a government-approved product. So what's left? We can write for compounded testosterone cream. It's messy, it's unreliable. Oprah Winfrey presented it on one of her shows, and her phones were ringing off the hook. But there are really very limited data about safety and efficacy. So it can be used for someone who's really desperate to try testosterone. It's unlikely to be much better than placebo, and it can have side effects. And what are some of the potential side effects? The biggest ones you might see are facial hair and acne. Again, not great for libido. We really don't expect to see, you know, virilization because we're using very low doses. Certainly shouldn't be used in women of reproductive age. There might be psychological changes. We did not ask women in our study if they could, on the testosterone patches, if they could still ask for directions at the gas station. But we did have a few women say, I don't know if it's placebo, but I really want a red sports car. And then, of course, we don't know about long-term safety, and I think at the end of the day, that's our greatest concern. Well, if I haven't convinced you that the answer is probably not in your medicine cabinet, I'll show you my favorite study. So what these researchers did is they took a group of about 2,000 young people between the ages of 19 and 32, and on the x-axis, the only thing you see here is relationship duration. So this is 2 months, and this is 90 months, so a few years. And on the y-axis, all they ask these men and women is, do you want to have sex often? And what you can see for men is that it was at about 80%, and it didn't matter how long they'd been in the relationship. And what you can see for women is in that new Steve, right? It was very exciting. And with time, the only thing that we're looking at here is relationship duration, pretty dramatic decline in libido or interest. So, you know, is that the second baby? Is that too many years of pee-pee on the toilet seat? No one can tell you what that is. But for women, relationship duration is really important. So I think the take-home message is, you know, novelty, making it more exciting, thinking about what was so much fun back at that 2 months that isn't nearly as exciting as 90 months is probably really the way to go. Not that there aren't some medications. Certainly you want to treat vaginal dryness. You want to adjust antidepressants. There are a lot of medical things you can do, but there's a lot you can do that is not in a medicine cabinet. So thank you very much. I think we have a little bit of time for questions.
Sure, there are a lot of questions after that.
Great.
I'll give this woman a microphone.
This is gonna be a good one.
Don't do it.
Dr. Schumer,
Yes.
What about the woman who, well, I'm in my early 70s.
We're not talking about individuals here. What about the person you know in her early 70s?
Okay, I'm good. That is not in any sort of relationship. How do you keep the juices flowing?
I actually think that's an excellent question because we try to be careful to say, you know, I have women who come in and say, you know, I have low libido and it's really bothersome and I don't have a partner. First of all, she might be concerned because it means she's less interested in doing all that energy that it takes to go out and get a partner. And I have some women who really do a lot, who really care about things on their own and that it's bothering them, that it's not as pleasurable. So, great question. I'd say you can think about a lot of the things still on this list. You know, getting enough sleep, getting enough exercise, optimizing body image, things like that. And it's hard to know what else might be really out there. If it's really important to you, if you've done all those other things, you could probably speak to your clinician about a trial of something like bupropion. But you have to weigh and balance, is it really worth taking a medication for that? Hope that was helpful.
Thank you.
Hi, I'm with Health Imperative, so we run the Nantucket Family Planning Clinic here on Island. So I'm wondering if you think asking about sexual function should become part of what primary care doctors do, primary care for sexual services? And if so, if there's age that you recommend for that, would you serve youth? How do we make that so that anyone that wants that information can have it more easily, but without forcing on those that are...
It's an excellent question. Whenever I'm speaking to healthcare providers, the first thing we talk about is asking about sexual health really needs to be a part of every well visit. And why do clinicians not do it? Time, right? So what I really encourage clinicians to do is ask a really simple question. Do you have any sexual concerns? And what I always say is if you have someone who has said yes to everything you've asked them, I'll say, do you have any really bothersome sexual concerns? But you do need to ask. And just a really open-ended question. And I've had a lot of women say, you know what, no one's ever asked me that before. And so then what I also tell clinicians is then if they say yes, and what you can see is at least 15% of women will, the answer to that should be, I'm so glad you told me. Sexual problems are really important for women, but we have so much to do in the 15 minutes that I've been allotted to do all the comprehensive stuff. Let's get your comprehensive visit done, your exam, your PAP, anything else you need. I'd love to see you back. And I'm going to see you back, and at that visit, all we're going to talk about is your sexual concerns. Now, that's first, of course, you have to certainly make sure that it's safe, consensual, sexually transmitted infections, and contraception. Those have to happen no matter what. But this more global discussion about things like sexual satisfaction, sexual concerns, does need to be asked. But you know what? We should really be bringing patients back for that, because there's just no way you can do it well in a short visit. What it means for you all as patients, bring it up. We have done some studies that even women with distressing sexual problems are really unlikely to talk to their healthcare providers. So bring it up. Don't bring it up with the door, with your hand on the door handle when you're walking out. Have it on your list, bring it up, and then if your clinician really seems kind of overwhelmed, to say, you know what, could you give me a referral? Is there someone in this healthcare system who'll be able to help me? And they'll know some people. Because again, not everybody really has the expertise, but they should be able to hopefully help you find a sex therapist, a gynecologist. So it should be in the purview of the internal medicine doc, but a lot of it is just making the right referrals. Great question, thank you. It's a very quiet audience for questions here. Yes?
Hi, what do you think about the G-shot amplification or the G-shot injection that is now out there?
Well, I don't even know about that, but what I will tell you is that I highly suspect that if you took a placebo G-shot injection, wherever it may be, it will be just as painful and just as effective. But I don't know what it is, so sorry. It certainly hasn't been studied in a double-blind randomized trial.
One more?
Hi, if you're taking a statin drug, would it be okay to use something like Vagifem or Eastern?
Absolutely unequivocally. Essentially, there is almost no one who cannot use Vagifem or Estring or vaginal estrogen cream. And I think that's really a take-home message. Very underused, incredibly safe, dramatic improvements in the sex life for postmenopausal women. So thank you very much. I'll be available after for any other questions. No, John, you know what, if you put it.
I feel empowered by Jan's excellent, though somewhat embarrassing talk, to tell you my feminist penis joke. Are you guys ready? What do you call the useless piece of skin on the end of a penis? A man. Thank you very much. All right. Boy, this is really not going to be as exciting as that last talk, I'm afraid. So I'm John Denninger. I'm the director of research at the Benson Henry Institute for Mind Body Medicine. This is where we study and figure out how techniques like meditation, yoga, and Tai Chi are helpful. And we think about the practice, but we also think a lot about the science. I'm not going to burden you with a lot of the science today. All right, stress is everywhere. Does anyone disagree with that, that our society is filled with stress? And did you notice? Stressed is dessert spelled backwards. All right, women's lives are stressful. I have an example, just a completely, absolutely hypothetical example. So take a woman around 50 who is struggling with, say, an aging mother, 2 teenage kids, and you know how teenagers are. They're not easy. And a husband who is, I can guarantee you, incredibly, incredibly well-meaning, but at times is almost like having a third child. Okay, yes, that's Helen Haley right there, my wife. And, Helen and I actually met in 8th grade at Boston Latin School. But it's not weird because we didn't get married until 9th grade, so it's fine. All right. The stress response, the thing that our bodies do when we're stressed, is something that was designed a long time ago by evolution that doesn't work so well for today's world. So let me show you what the stress response does. So when you are afraid, when you in the old days were being run down by a predator, when you were in a fight, something like that, this is what your body does. In the central nervous system, in your brain, essentially it puts you into fight or flight mode, right? Fight or flight mode is, I'm going to survive this or I'm going to run away. And so the brain is not making a lot of fine, detailed decisions or anything like that. All it's doing is focusing with tunnel vision on what's going on. Your muscular system is getting ready for battle. Your muscles get tense. You're ready for action. Your jaws clench. And then the autonomic nervous system does all those things that we recognize in ourselves when we're stressed, right? Heart rate goes up, blood pressure goes up, increased need for oxygen, your palms start to sweat, you breathe faster. This is great if you're running from a saber-toothed cat. Fantastic. This is not so great if what you're doing is encountering the kinds of stresses that we all encounter. If you're on your email and you get a nasty email from your boss. If you encounter something in your daily life that reminds you that, oh my gosh, my taxes are due, or oh my gosh, I have this presentation I have to give. These are all things, these are the kinds of stresses that we encounter every day. And the fight or flight response, the stress response, was designed to protect us in the case of acute stresses. When we are exposed to these over and over again, they can cause wear and tear on the brain and body that causes harm over the long term. All right. What's the solution? Oh, one more point. For women, it's important to point out that this is not just happening in the body system in general. Stress is also, and we don't need to go over the details here, but stress is also, oh, you're not seeing that. All right. On the right side here, this is the hormone system. And I just want to make the simple point that women's hormonal systems are also affected by stress a great deal. Can you guys still hear me when I turn my head like this? Yes, because I talk loud, yes. All right, this is Herbert Benson. So he's the founder of the Benson Henry Institute. He's our director emeritus. And he back in, does anyone remember this book, The Relaxation Response, from the mid-70s? So Herbert Benson was one of the people who early on looked at these techniques that existed in societies all around the world, techniques like meditation, for example, and said, and actually found evidence that suggested that these techniques might be helpful in solving problems in human health and disease. So he wrote this book, The Relaxation Response, and he named the relaxation response to be opposite of the stress response. His idea was that, well, if you had this thing that caused stress, where your body had a certain reaction, he had found that meditation and other similar kinds of techniques can cause the opposite kind of response. So instead of raised blood pressure, raised heart rate, raised metabolism, the relaxation response is a state brought about by techniques like meditation, Tai Chi, and yoga, which decreases heart rate, lowers respiratory rate, and increases exhaled nitric oxide. So that's what the relaxation response is. Anyone know this guy? Jon Kabat-Zinn? So Jon Kabat-Zinn, working around the same time, took the Buddhist concept of mindfulness and brought that into medicine here in the United States. And I really love his definition of mindfulness. Are you guys familiar with that term? It's certainly a buzzword these days. So mindfulness is awareness that arises through paying attention on purpose in the present moment and non-judgmentally. And that last word, non-judgmentally, is, I think, the really key phrase. We can be present, but if we are paying attention to ourselves, our own thoughts, in a judgmental way, it's hard to achieve a position that is that lowers stress. All right, meditation. Who here has tried meditation? We're going to try it in a little while. Oh, that's excellent. My gosh, that might be the highest number of any crowd I have ever encountered. I am very proud of all of you. So meditation is just one mind-body technique, and we teach a lot of different mind-body techniques at the Benson Henry Institute. Meditation is a tradition that comes from many, many different cultures, whether it's meditation, repetitive prayer, or the like. And the way we think about it, the way Dr. Benson has been talking about it for years, is meditation is something that breaks the train of everyday thought. So it gives your brain an opportunity to get away from the worries that are typically running through it. And who doesn't have that kind of stuff running through their heads all the time? One thing I like to point out, meditation is not a contest. There are so many people, patients, colleagues, friends, who come to me and say, I can't do it. My mind is too busy. I'm just not good at it. It's not my thing. The thing to remember is that meditation is a practice. It's not something you succeed at or fail at, right? So it's something that you get better and better at over time. It's something that you can't think of as you're trying to best the person sitting next to you. Also, one thing to remember is we're all human. You cannot make your mind stand still. It's impossible. The Dalai Lama cannot make his mind stand still. I am certain that he manages longer periods of time of stillness than I manage, but there's no way to blank the mind as a human being, unless you're unconscious or something like that. Then it's easier. So as I always tell people, achieving some kind of sustained focus is a journey. It's not a destination. It's not some place you get to. It's something that you're always working toward when you're meditating and at other times. And what I am certain is both completely normal and is expected in meditation is this cycle that I have on the bottom here. So you manage to sustain your focus. Maybe it's for, I'm happy if I get 5 seconds without an intervening thought, right? You sustain your focus for 5 seconds. Then your mind wanders. You notice it, and then you bring your mind back. And there's a great Scientific American article, for those who like Scientific American, by Mathieu Ricard and a few colleagues, where they talk about a study where they took experienced meditators, they put them in the MRI scanner, and they actually were able to see these changes when they pressed a button, if they noticed their mind wandering. They could see them reestablishing their focus, and then they could see them in the focus state and then seeing their mind wandering as well. This is something that is perfectly normal, and I am certain that much of the benefit in meditation comes from going through this cycle. So if your mind is wandering, that's okay. All it's about is noticing it. All right, who here does yoga? Corpse pose, Shavasana, that's often at the end. Can you guys read this? I can read it to you. So the instructor is saying, your eyes are quiet, your ears are quiet, your brain is quiet. And the first person is saying, what time is it? Oh God, I'm going to miss my meeting. What's that little pain in my left arm? A pinched nerve? A heart attack? Oh no, I bet it's a heart attack. The other person saying, will I ever amount to anything? I'm wasting my life. The last person, what the hell is wrong with me? I bet I'm the only one here who's not totally relaxed. All right. This is not the stuff we want to be happening. I mean, it's okay to have those thoughts, but what you need to be doing is just noticing them non-judgmentally, and then coming back to whatever you've chosen as your focus. All right, are you ready to try? I know there are a lot of experienced meditators in here. Oh, go back for 1 second, sure. We're taking photographs. This is a photo opportunity. All right. This is not the beach here. This is a Nantucket Beach, a little closer to Boston. What I'd like everyone to do, if you're comfortable, is first just rest your feet on the floor, flat on the floor. Take stuff out of your lap, put it on the ground. Rest your hands in your lap, or as you're comfortable. If you're comfortable doing so, you don't have to, but if you're comfortable doing so, you can close your eyes. If you're not comfortable closing your eyes, you can just adopt a soft focus on the ground in front of you. And why don't we, just to get ourselves in the mood, just shrug our shoulders a couple of times. Maybe let your head fall to your left shoulder, just very gently. And then up to the top again, and then down toward the right shoulder, just gently. And now upright. And just allow, I like to think of the crown of my head sort of aspiring toward the ceiling. Some people like to imagine a string tying the crown of their head to the ceiling. Back straight but not stiff. Always a position that supports comfort. And what I'd like you to do is just take one deep breath in and then release it. And then just let your breath adopt its own natural rhythm. Let your body breathe, it knows how. And as our focus today, I've chosen the word love. Because this event seems like one that is filled with love in many ways. And what you can do is just, on the out-breath, say love silently to yourself. And if for some reason that's not a comfortable word for you, you can choose another word or phrase, something that's meaningful to you. Again, in-breath and love on the out-breath, silently to yourself. Thoughts are going to arise in your head, but all you have to do is notice them. Just notice them and turn back to your focus. No judgment. If you notice your mind wandering, you can always come back to the breath. The breath that's always there, moving in and out, Belly expanding and contracting. Breath cool on the in-breath, warm on the out-breath. And then as you are with your breath again, come back to your focus. Come back to love, or whatever word you've chosen. As thoughts and emotions come into your consciousness, the important thing is to notice them, and notice them without judgment. Let them be. Let your brain do what it does, and just gently return to your focus. Now, as we come to the end of this brief meditation, what I'd like you to do is just allow your attention to come back to the room. Start thinking your regular thoughts. And when you're ready, as you're comfortable, allow your eyes to open and come back to the room. How's everybody doing? It doesn't, I mean, another thing that's very important to note is that not every time that you meditate is going to be relaxing. That's one thing Dr. Benson and I'm not super fond of the term relaxation response because I think it gives a little bit of that sense that mind-body medicine is about, chilling in front of the TV, something like that. And so it's not always relaxing. Did anyone have any experiences they wanted to share?
I was going to fall off the chair.
Feeling tired? Yeah. And if you are falling asleep when you're meditating, it's not bad. It means that your body is saying, you need more sleep. And so that's never something to worry about. And you'll find, with more practice, you will find it easier and easier to maintain awakeness as well. Though the EEG changes during meditation are very similar to stage 1 sleep. So it's not surprising. Yeah, Melanie.
I had never meditated.
Yeah.
And that was, wow, it's powerful.
Oh, good. I'm glad. I'm glad. It's a wonderful practice. It's not that one of my themes today is going to be that it doesn't matter so much what practice you choose. We think that it's important to choose a mind-body practice, just like it's important to have good nutrition and exercise, et cetera, to choose a mind-body practice that you do every day. It doesn't have to be meditation, and there are many different kinds of meditation, but doing something like yoga, tai chi, et cetera. Was there another question here? Yeah.
I just find it so interesting that I do meditate sometimes. I can't say I'm regular, but times I am, and it's very relaxing. It can calm me in a hospital setting, whatever, it really works. But whenever I do it in a group, there's something almost religious about it. There's something about the community of people around me. There's some people in this room I know and some that I don't know, but it feels really good to do it.
Yeah, I think there is something different about group meditation versus solo meditation. Both very powerful in different ways. Yeah. Yeah.
I'm glad you said what you said about not expecting it to be completely relaxing every time, because
Yeah.
I have always felt like I've failed in my efforts to do it because it can be disquieting. It can be disquieting, I think.
Yeah.
You know, as a mother with young children, very rarely do I have a few quiet moments, and usually that's a scary thing.
Right.
So I'm glad you said that because it takes the pressure off.
Yeah,
You
yeah.
know, because I kept thinking, doing this.
Right, right. And that's, if I dispel one misconception, that's a great misconception for me to dispel. Great. Okay, great. Thank you very much. Thank you for participating with that. Well, I'm not done. I was thanking you for meditating. Oh no, I've got another couple hours. Don't worry, don't worry. We're going to be getting into biochemistry. No, I do have just a few more slides. I just want to say, so this thing we just did has demonstrated benefits. So some of the cognitive changes that are associated with meditation are, and one of the reasons why I save this stuff for after the meditation is because this is the stuff I really want you to remember. And it is easy to remember things after doing a mind-body practice. It appears to be, I don't have empirical data on this, but it appears to be easier to implement behavior change. All the stuff we've been talking about, the things that you need to do in your life, nutrition and exercise, et cetera, you seem to be able to initiate those kind of behavior changes when you have these, when you've been meditating. So better attention, better working memory, increased functional connectivity in the brain, the different parts of the brain talking to each other more, decreased reactivity to negative emotions and negative emotional stimuli, and increased awareness of thinking about your thinking, metacognition as they call it. And one possible mechanism for this is actual growth in brain, actual growth in gray matter in brain that our colleague Sarah Lazar at Mass General has demonstrated, so increased cortical thickness in certain brain areas. We at the Benson Henry Institute, and now many other groups around the country and around the world, have been working with doing experiments with genetic expression. And again, not to get into the deep biology here, which I am interested in, but I won't burden you with. But meditation and other kinds of mind-body practices have been shown to be able to turn on and off genes in a pattern that appears to be beneficial. Things like turning down genes related to insulin secretion, which has implications for diabetes, enhancing genes for insulin secretion, enhancing genes for telomere maintenance, which has implications for aging. Telomeres are the end caps of chromosomes, which get shorter and shorter as you age. And then reduced expression of genes related to the inflammatory response. Have people gotten the sense that inflammation, although we need it, if you cut yourself, you need it to get red and the immune cells to go and do what they need to do. But inflammation at high levels throughout the body is dangerous and contributes to everything from heart disease to probably psychiatric disease. I'm a psychiatrist, to psychiatric diseases like depression. So these techniques have the potential for decreasing inflammation in a whole body way. Just one slide at midlife, not because I'm living with someone who happens to be around that age. Oh, people are laughing at this 7 Dwarfs of Menopause there. Read it because it's probably not visible today. Itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. I got that from Leslie Kagan, one of our nurse practitioners. The relaxation response and meditation more generally has been shown to reduce intensity and frequency of hot flashes and the bothersomeness of those kinds of vasomotor symptoms around midlife. There are also benefit for other kinds of techniques like yoga and mindfulness-based stress reduction, also for things like insomnia, which can be incredibly helpful. All right, we're almost home stretch here, almost done. This is the last slide, essentially. This is the resiliency toolbox. These are the things I want you to take away from today. So the first thing is practicing the relaxation response, which can mean any kind of practice: meditation, yoga, tai chi, qigong, mindful walks on the beach, for example. What a wonderful place to do that here. A practice that fits you, and it doesn't have to be the same thing every day for you. It can be different things at different moments in your life. It can be different things across your lifespan. It can be different things on the weekend and during the week. But do something. And when you don't have time for that, or even when you do, mini relaxations are fantastic. You can do what we did just now. You can do it for a minute. Focus on your breath for a minute. I had a surgeon colleague who would CalStat in the hospital. He would CalStat his hands. While he was sanitizing his hands in between patients, would just do a quick, close his eyes and just do a quick breathing exercise to kind of clear whatever had happened with the prior patient and be ready and open and present for the next one. And that will work for anybody. You can do a mini, you stop at a traffic light, don't close your eyes, because you want to be ready. but you can focus on your breath for just a few seconds. Or you can, take a minute or 2 minutes or 5 minutes to do some breathing and focus on a mantra, etc. Or even just pause and be mindful of the sounds around you, the feelings in your body, etc. Mindfulness is something, as I was embarrassed one day when I was talking on the podium with John Kabat-Zinn, I kept calling these techniques. Very sciencey of me, techniques. And he got up and said, mindfulness is a way of life, right? And really that is a great way to think about it. This is something, the ability to be in the present, on purpose, in a non-judgmental way, is something that we can all benefit from and that can incredibly benefit our health. And not only that, I have no doubt that there's a little bit of a, all boats rise on the rising tide. Like, if everyone has that sort of approach to life, it calms everything down for everybody. And so we may be having a hard time, but if people around us are more mindful, it helps us as well. And then the things, and we've talked about this so much, sleep is incredibly important, 7 to 8 hours a night. I know it's hard, but it's worth it. And if you don't get it, you're not actually being more productive. You feel like you are, but in the long term, you're making your productivity worse. Nutrition, eat well. Melissa talked a lot about that. Exercise, so important. Again, we've heard about that already. Humor is great. This is one of the great things that human beings do. If we can approach life with humor, we can conquer so much, and we can get over so many of the things that are difficult in our world today. And then finally, and what better place than in a crowd like this to talk about this, amidst these people who've been such wonderful hosts to us, just outstanding, is social support. People coming together to do wonderful things, to help each other, whether it's on an individual basis or on a group basis like this wonderful group. So anyway, I'll just leave you with an invitation. That's me with my kayak in that little dot. You probably can't see it in the back, at the shoreline right there. It's not just a little schmutz on the slide. So an invitation to the Benson Henry Institute. We run a conference, continuing medical education conference every fall. It's October 19th to 21st. Everyone is welcome to come and join us there. We always have online courses available. And it's a little bit of a commute from here to the Benson Henry Institute, but we have a program, the Stress Management and Resiliency Training Program, that we offer. That's an 8-week program. We are gearing up to do more telemedicine type programs, so that over like video conference, so that people here or back home, if it's far from Boston, can also join in. And of course, there are many, many places around the country and around the world where mindfulness-based stress reduction is taught, and all other kinds of mind-body practices. And I encourage you who haven't tried it to try it, those who have tried it to keep doing it. Thank you very much.
meditation that really blew my mind was how it worked in prison, and in particular a prison in Arkansas, which leads me to think, to wonder, are these ways of life being introduced in schools?
Absolutely. So that's a great idea. And yes, there is definitely a move all over the country to bring these kinds of techniques to schools, to kids. Kids are one of the, the most recent data suggests that kids are actually the most stressed group, which I guess for many of us doesn't surprise us. I mean, one of the things about, people who've been alive for a little bit, we've been through some stuff, right? And so you learn how to sort of roll with the punches. Kids are facing so much these days that they don't necessarily know how to roll with the punches yet. So yes, there's a huge effort to bring this to schools. One thing, I'm a scientist, I'm a researcher, so one thing I always think about is the tendency to hear about something and just implement it without testing it. We really do, it's great stuff. I don't think you can go wrong teaching people this, but I would love to see some really, really well done studies, like large studies that show that this is worth the time and money that it takes to do. And the other thing to think about in schools is the difficulty with, curriculum. The curriculum's already super crowded. And so every minute that you try and take stuff out is difficult. So it is a great idea. We're definitely thinking about it. We have a whole mission at the Benson Henry Institute focused on that. And there definitely are movements afoot. Yeah.
I just wanted to ask if I eat more desserts, does that mean I'm going to have less stress?
Yes, that absolutely will do that. I went to the juice bar twice while I was there. And
my real question is, so I wanted to add humor in, since you said that was one of the seven
yeah.
factors. But with the reduction of the stress and the benefits of the overall, it doesn't affect your body in a positive way with your hormones and neurotransmitters because it is reducing the stress.
Yes, I think we can say very, very clearly that in general, reducing stress. Stress is not bad. I don't want to give the impression that stress. Actually, Kelly McGonigal has a great YouTube talk on how stress is not always bad. There is eustress, we call it good stress, which is that we thrive when we stretch ourselves, right? It's when stress is incredibly chronic and when you're approaching it with a negative attitude that it can be especially bad. So I don't want to demonize stress, but yeah, these techniques are wonderful for actually bringing about changes, physiological changes in the brain and body that are positive for health. That's the big message. Others.
I use the Headspace app.
Oh, yeah.
And I found it amazing. And I was just wondering have you ever used an app or?
I maybe spent 5 or 10 minutes trying out Headspace. We recommend all of these apps to our patients all the time. They are incredibly helpful. One of the great things about living now is that there are a huge number of resources out there online and elsewhere. Oh, that's another thing I wanted to point out. A lot of the embarrassing things that Jan was talking about, those are available online, You don't have to go to the local bookstore. I believe in supporting the local bookstore. But that might be a case where Amazon might be a good. But anyway, yes, we recommend those apps all the time. I don't endorse any particular one or anything like that. I've heard very good things about Headspace from a lot of people, including some people who have worked for me in the past who really, really like it. So yeah, absolutely.
Thank you very much.
Thank you.
Thank you.
Now what?
Thank you.
Thank you.
We're so proud we have MGH as partners of our house. And I think the doctor's energy, their enthusiasm, their expertise is extraordinary. Did this program meet your expectations? Did it? Did the topics were relevant? Did you feel? Did you feel the topics were relevant? Yes. Okay. Because this is number one, Women in Wellness. Lots more to come. And I just want you to know that we want your opinion. You're going to see it inside your program. Tell us what you want to hear. What's important to you? Because again, we have just launched this, and it's. I think next time we're going to have a much bigger venue. What do you think?
The business discussion, I promise the doctors will be around, so we want to get to everybody, so I know we just ran short on time with this wonderful program. And I just want to say a special thank you to Margot, Courtney, and the staff, and our wonderful hospital here in Nantucket. We are so lucky, 30 miles out to sea, to have a quality hospital that delivers compassionate care every single day. This is a hospital that operates in crisis mode 24/7. They still do rates and fast hospital care, and we're so fortunate to have a new hospital across the main building. It's not, you've seen the construction site, but it's just getting better. And we hope we'll all be participating in this special once-in-a-generation opportunity to get to know this world.
Okay, and I want to thank each and every one of you for coming, because you're the ones who made this a success. And I also want to thank the foundation staff. If you're here, please stand up. Courtney O'Neill, who is our Burlingham, Shane McGuire, Beth Moyer, Molly Linkowski, Jason, where are you? Did you?
Thanks. Let's continue to network. Our doctors are going to stay, and thank you everyone for coming.